Percutaneous dilatational tracheostomy is a simple, cost-effective alternative to standard open tracheostomy. This approach also results in less trauma to the patient and is routinely performed bedside. The Cook Chaya Blue Rhino percutaneous tracheostomy introducer set has been designed for controlled elective insertion of a tracheostomy tube. The improved design of the Blue Rhino has a remarkably flexible tip for a less traumatic approach. Its soft, pliant, curved contour is passed over a guiding catheter to create a proper tracheostomy opening in just one pass. The Blue Rhino's slippery hydrophilic coating and tapered profile eliminate the need for multiple passes with increasingly larger dilators, making the procedure quicker and possibly decreasing the risk of tracheal wall trauma. And the Blue Rhino is also cost-effective because it can be used in a bedside procedure, avoiding OR expenses. Indications for a percutaneous dilatational tracheostomy are identical to those for conventional surgical tracheostomy. Absolute contraindications include emergency tracheostomy, pediatric applications, the presence of a midline neck mass, and non-intubated patients. Relative contraindications include a PEEP value greater than or equal to 20 or uncorrected coagulopathy. Sedation includes a combination of intravenous analgesics, anxiolytics, and short-acting paralytics. The patient should be placed on 100% oxygen with volume adjusted to compensate for the presence of the bronchoscope. For this patient, a fenestrated tapered tracheostomy tube with the intercannula removed is preloaded with an appropriately sized lubricated dilator. However, any standard tracheostomy tube may be used. The tracheostomy tube is positioned so that the tip is approximately 2 centimeters from the distal tip of the dilator. First, the patient is positioned as for a traditional tracheostomy with a transverse shoulder roll to permit full extension of the head and neck. The neck and upper chest are sterilely prepped and draped in the standard fashion. Critical anatomical landmarks, the thyroid cartilage, cricoid cartilage, and the sternal notch are identified by palpation and marked. The incision site is infiltrated with 1% lidocaine with epinephrine. A 1.5 to 2 centimeter transverse skin incision, just long enough to admit the tracheostomy tube, is made at the level of the first and second or second and third tracheal rings, approximately 1 finger breadth above the sternal notch. A curved mosquito or hemostat may then be used to gently separate the subcutaneous tissues vertically and transversely. Digital palpation is then used to free any tissue while identifying the cricoid cartilage and the tracheal rings through the incision. A bronchoscope is then inserted through the endotracheal tube and aligned with the tube. The respiratory therapist then loosens the fixation tapes of the endotracheal tube, deflates the cuff, and withdraws the ETT and bronchoscope slowly as a unit until the light from the bronchoscope transilluminates through the incision. Necessary changes in tidal volume and frequency should be made to accommodate the bronchoscope and any air leak that may occur during dilatation. Access and ultimate tube placement is made at the level between the first and second or second and third tracheal rings. Tracheal rings are palpated, and a 15-gauge introducer needle is inserted in a midline and intercartilaginous position under direct bronchoscopic visualization. Care is taken to avoid the posterior tracheal wall. The needle is removed, and the 52/1000-inch J-tipped wire is threaded through the outer catheter into the trachea to the level of the carina. The sheath is then removed and replaced by the 14 French introducer dilator, which is advanced over the wire guide to dilate the initial access site. Some compression of the anterior tracheal wall is expected. The dilator is removed and replaced by the 8 French guiding catheter, which is advanced to the skin level mark on the wire guide. The guiding catheter and wire guide are inserted as a unit into the trachea until the safety ridge on the guiding catheter is at the skin level. Proper positioning of the guiding catheter can be constantly confirmed by aligning the proximal end of the catheter with the proximal mark on the wire guide. This will prevent displacement of the J-wire and possible trauma to the posterior tracheal wall during subsequent manipulations. Lubrication of the dilator is accomplished by dipping the tip of the dilator into sterile water or saline. This activates the EasyPass hydrophilic coating. Dilation of the access site into the trachea is then accomplished by advancing the Blue Rhino dilator over the wire guide catheter assembly. To properly align the dilator on the assembly, advance the distal tip of the dilator to the safety ridge on the guiding catheter. The dilator is held like a pencil and advanced with a curved arcing motion into the trachea until there is a loss of resistance. Repeated advancement and retraction of the dilating assembly effectively dilates the tracheal access site. The aperture should be slightly over-dilated, thereby facilitating the placement of the tracheostomy tube. After verifying its integrity, the tracheostomy tube is completely deflated and lubricated. The tube is then advanced over the guiding catheter J-wire unit to the safety ridge and then introduced into the trachea under direct bronchoscopic visualization. Next, the blue dilator, guiding catheter, and J-wire are removed. The inner cannula is then inserted and the cuff is inflated. The ventilator tubing can then be connected and the endotracheal tube is removed. The tube is secured with 4 corner sutures and tape. Postoperatively, a radiograph is recommended to rule out pneumothorax. The site is cleaned with sterile saline and dry dressings are applied as needed. Kits and trays are now available with a Mallinckrodt-Shiley PERC tracheostomy tube along with the appropriately sized blue dilator. For more information about the Cook Chaya Blue Rhino tracheostomy introducer set, please contact your local Cook representative or call 1-800-457-4500.